questions there about surgery, about adjuvant chemotherapy, adjuvant radiotherapy, and PDT. Are there any questions from the audience? Well, if not, I'm going to start. Thomas, you operate and do liver resections on metastatic disease and on primary tumors. There is a difference, I think, in the liver, unless we give a lot of chemotherapy, which we sometimes do for metastatic disease, oxaliplatin and irinotecan. My liver surgeons certainly don't like it when I give a lot of that. But in the primary tumors, partly because of the etiology and partly because of the obstruction and things, your liver isn't as good. So are there any concerns about giving neoadjuvant chemotherapy and then resecting the liver after neoadjuvant chemotherapy?
Yeah, the first problem is that you have to get these people with normal bilirubin, which you very hardly get. And as long as they have a bilirubin of 5, you're not going to give any chemotherapy. So therefore, the question is, I mean, if the patient has, for example, an intrahepatic cholangio, then I'm more than happy to give chemotherapy because usually their livers are normal. And we only give 2 months of chemotherapy to evaluate response. So in intrahepatic, I would do it tomorrow. In Kletskin tumors, it's a bit of a problem.
But it doesn't. The question I'm asking, it doesn't concern you to give the chemotherapy. It doesn't complicate your surgery.
Well, at the beginning, when we started resecting patients after chemotherapy for metastatic disease, the livers were falling apart, being blue and yellowish. That's not the case anymore with the antibodies nowadays. But I'm still concerned if a patient is shown for the first time after 6 months of chemotherapy, which I had, for example, last week, because the liver is it's not steatotic, it's just accuser. You just have to, half a centimeter apart from the liver tissue already is away, so that the tissue is really strongly alterated by the chemotherapy.
Okay. Thank you.
I do have also a question regarding the cholestasis. So actually we can also give Folfox in patients with bilirubin more than 20. You can reduce the dosage, of course, but it can be given. However, my question is, in our tumor conference we discussed with Hauke Lang, who is also a quite good liver surgeon. He always says,
excellent liver surgeon.
If the bilirubin is more than 10 or even 15, he can also operate directly. So is that, what is really the role of the drainage? Do we need it? Or do we need it only if the patient has inflammatory signals, signs? So what is, when do we really need the drainage, and what would be the bilirubin levels?
So so the mentioned surgeon is an excellent, not only a good surgeon. And the problem is always if you come with results from excellent surgeons and try to elaborate it to the whole audience or the whole surgeons that are available, it's usually the case that if somebody does it once a month, it's not getting as good as if somebody is doing every day. So therefore, if a patient has elevated bilirubin, generally, you would have to say you have to preserve more liver than if the patient has a normal bilirubin, because the liver does not work as well as in patients that have not obstructive jaundice for several days or weeks. And if you give Folfox to a patient with 20 bilirubin, the dosage has so much to be reduced that it does not work. So I would not recommend doing that.
Okay, I mean, we have seen some good patients with it, but I agree. I mean, this cannot be said as a typical indication for everybody. Yeah.
And the problem, if the patient has then an inflammatory problem under chemotherapy with 20 bilirubin, is going to be really sick.
But this brings me to the neoadjuvant chemotherapy. What we have done also is using FOLFIRINOX as a neoadjuvant strategy, and then went for operation. Do you have also results for that?
We have only results in metastatic setting. We have not results in cholangios.
Manfred.
Yeah, thanks very much for your presentations. I think they show quite well that we don't really know what to do best, right? I was hoping after the session that we could sort of select the patient for radiotherapy or chemotherapy, something like that, but that's not the case. Can you help me? No, actually, the rationale now would be to go home and say, I mean, we don't do any adjuvant, we don't have any evidence for it. It's all retrospective, and we do surgery and that's it. But then, on the other hand,
but we're going to have results at the end of this year, at least.
Yeah, probably.
Yeah.
Yeah. But if you would nowadays try to select a patient for, say, neoadjuvant photodynamic or adjuvant chemo or adjuvant radiochemo, how would you select the patient? What would be your criterion to select one patient for one treatment or another one?
So based on the results we have available from last year, every patient with lymph node metastases and R1 resection is receiving chemoradiotherapy in my center. But I'm also looking forward to the results of these two trials because John already is quite where is he? He's already in a conference. No. So based on the results, because he said to get half of the patient to an endpoint, dying, took 10 years. So obviously there is a major benefit from what he studied. So we're really looking forward to June or whenever ASCO is starting.
So we have to wait for ASCO, I think. But is it really only R1 and lymph node metastasis which decides if the patient is distant relapser or local relapser, or there are other factors? I mean, we tried to answer that in the session before, but I mean, it's the same question here. What makes a patient go this way or another way other than lymph nodes? Yeah,
but the problem with lymph node metastasis is I don't have a single patient that had lymph node metastasis and was not recurring.
Okay.
So this is just dismal disease.
And the others?
The other ones
are zero lymph node negatives?
Yeah,
I mean,
they are better, but they're also recurring.
Is it a surgical problem?
Probably we should not do surgery in them. But I just talked to Hauke Lang at the meeting in Wiesbaden last weekend. And we talked about the patients we have with cholangiocarcinoma that did not recur. And they are here. Yeah? So not very many. So therefore, it's important that we decide on what neoadjuvant or what adjuvant treatment should we give. But so far, we have not been able to do any decent studies, except in England, where the benefit of NICE is that nobody gets any treatment. So therefore, you have to go on to a trial to get the treatment.
Now, might there be hope? I mean, to looking at his data, it's all retrospective and very small patient numbers. Photodynamic therapy or maybe brachytherapy before surgery might have the advantage of getting a locally highly effective therapy before you resect. Is there any hope in there?
Yeah, I would send immediately a patient to him. My problem, the problem of my quite good SBRT people is that they say, oh, there is the duodenum in contact, so I can't give the whole dose. If they're not giving the whole dose, it's basically useless. That is my experience.
The problem in neoadjuvant therapy, the problem is that we can see a response of a high response rate if you use very high dose of brachytherapy, high radiation, external beam radiation therapy, and brachytherapy or stereotactic body radiation therapy. And this is a little problem for the surgeon when he have to do the surgery because of fibrosis. So neoadjuvant adjuvant radiotherapy, it's used only in some study for a patient candidate to transplantation.
I think you always have the problem of local toxicity after the neoadjuvant treatment. So with you, it would be fibrosis. So would you normally operate after, like we do with 5x5 in the rectum immediately afterwards, or do you wait for 6 weeks?
You're hopefully not operating anymore immediately after 5x5. Or Rob, what would you do after 5x5?
Well, I'm just interested in, do you have problems with your oncologists that you don't have a biopsy?
No, because I have one at home.
You tell them what to do, okay. But do you have problems with your oncologists that you don't have a biopsy? See, we have a cholangio study with CyberKnife, but they are insisting that you have a biopsy. We get sometimes patients that are very difficult to get histological confirmation.
Yeah. That's a real problem because there are at least 2 cases that I'm aware of where the patient did not have tumor, and then he sued the oncologist, so therefore they said, we're not going to do this anymore without histology.
So you do have problems?
Yeah.
I still need an answer.
Not at home.
I still need an answer. 5x5 immediate surgery, or do you wait for 6 weeks if you do the approach in cholangiocarcinoma?
The response of cholangiocarcinoma is with radiotherapy with 6 weeks. It's not very high. But also with 5x5, the equivalent dose is similar. I don't think that 5x5 can change the rate of response.
But the disadvantage of 5x5 is that it is hard to combine with chemo, and your retrospective data show that radiation alone is less good than the combination of chemo radiation. But it's all retrospective, right?
Our retrospective data, but radiochemotherapy is a little better than radiation therapy alone.
Do you think there is a role for intraoperative radiotherapy?
We had used this in one hospital. I have never used it, and it basically was abandoned. But I don't know if it was abandoned because of lack of efficacy or problems with anastomosis afterwards. I can't tell you. I don't have any experience with it.
Sorry, I would like to squeeze you a little bit more regarding the chemoradiation. I mean, you already mentioned the data of the Rochester Mayo Clinic, the chemoradiation and transplantation data. This is a highly selective group. However, many colleagues say there is a signal for that. So what would be your strategy, your study, which we should go for in the EORTC?
I think that the data of Mayo Clinics are very, very interesting, but is data that use radiochemotherapy as a bridge therapy until to transplantation. And some other authors use also brachytherapy, similar schedule of Mayo Clinic, and adding also brachytherapy, and with result improved. The problem is if the patient is candidate to a transplantation. I don't have experience because in our country it's not possible to transplant a patient with a cholangiocarcinoma. The politics it's closer, so could be a strategy, but you have to provide a transplantation. It's a bridge therapy for me.
anyone else than Mayo having large experience with transplantation? I mean, they have a highly selected patient population, and a lot of patients, I think they are young and have PSC or something like that, with a sort of special type of cholangiocarcinoma, which has a better prognosis than others, probably, right? And that's not our sort of 70 or 60-year-old patient who turns yellow and needs operation. Does someone have experience other than they? Do you know, Thomas?
I can't. There are other experiences not as good as the ones from there, so that's why others have stopped their ideas. But I can't quote where it is, and
just there.
So we have not used it in at the Viennese.
Can I ask a question to Gernot? I kind of try to get around the toxicity of neoadjuvant or potentially neoadjuvant therapy. If you do photodynamic therapy before surgery, can you operate easily, or is it a problem with the light afterwards?
The light has to be dimmed, and the exposure to light has to be reduced. But if you observe this, then it's easily possible. So because we had also in the last trial, we had 3 patients who needed to have operation on, also for the cholecystectomy, and it was possible. There was no adverse effect on the result of this operation. So this is possible.
I have only one question. I think we all agree that cholangiocarcinoma is now a systemic disease. So chemo before or after is the one question that we have to it's an issue. But outside of clinical trials, what is the best scheme? I don't know, because sometimes we do gemcitabine, others do cisplatin plus gemcitabine, others do capecitabine. We don't know. What do you use?
We don't know it either. we still, as we had that quite great results with the combination of Gemox and cetuximab, we still use this in some patients where we are aiming for downsizing, so we're giving this 4 cycles, meaning 2 months, and evaluate if the patient is benefiting. If he's not benefiting, we stop the cetuximab. If he's benefiting, we then have a secondary surgery in these patients.
At my country, Portugal, is that with you use Gemox, but in neoadjuvancy, because in the trial of second phase, it has a lot of toxicity and not as good results. So we have the problem with Gemox. We do it in 2nd and 3rd line in pancreatic cancer. As neoadjuvant, we cannot do it. So it was a question.
Sure. I mean, I don't see that amount of side effects if you're giving it 4 times, which is 2 months.
I don't know. I don't think also, but if I go to my hospital and I want to do Gemox as neoadjuvant treatment, they don't let me because we don't have approved level A.
Can I just pick that up? I mean, I'm always playing the awkward sod in the thing, but is it really a systemic disease if 50% of patients are getting a local recurrence, and most of the patients die of, well, either vascular or obstructive symptoms and liver failure, don't they? They don't really.
Are we still only talking about the
extrahepatic cholangiocarcinoma?
I'm not too sure if 50% get a local recurrence. So my experience is that they are getting systemic disease.
Don't most of the patients...
And if you again compare intrahepatic to Klatskin tumors, usually the time to recurrence is longer with Klatskin, and you're getting systemic disease with Klatskin. That's at least my experience.
You see more, but aren't you still having a degree of patients dying just of liver failure, of obstructive and vascular problems?
This is actually also what I see. It's more common that they die because of liver failure or bleeding or complications, local complications of the tumor, and not due to the systemic.
But not resected patients or resected patients. Are we talking about the palliative patient? He's going to have a problem with the local failure, local obstruction of vessels.
I actually talk about the palliative patients because most of the patients are palliative patients. And if we say it's a systemic disease, yes, it is a systemic disease. However, it takes time until it is a systemic disease. And in the meanwhile, we face the problems, the local problems. And I think for this time, we have, until it is a systemic disease, we should care for what is going on at the liver side. And then, if it comes to the systemic disease or the systemic progression, of course, then we have to deal with that. But they need to get there at first place.
Yeah, but we are still talking about two different things. So what you are talking about, I completely agree. If we talk about the obstructed patient, we have to release the obstruction, otherwise we can't do anything about his disease before it becomes systemic. And the second part is that we're talking about patients that will have a recurrence, which is a systemic recurrence more often than a local recurrence.
Yeah.
Just a short comment in the question. First, the comment on the photodynamic therapy. Several years ago, we were very enthusiastic, and we did this in our clinic. But as just briefly mentioned, this is really, really dangerous if the patient needs surgery shortly afterwards. We had a patient with a perforation, and you can't use the light. You need other light sources. So you're really in a problematic situation if you need surgery in a patient after photodynamics therapy. This is an unsolved problem, to my knowledge. Do you have any other ideas?
What we do in this situation is that we try to completely cover the patient. So that, first of all, even if we send them to the operation theater, he or she will be completely covered. And each spot of the body will be covered. And we will also change the site for the clip where we measure the oxygenation of the blood. We will always move. Once every while we move to another, to another place. But also for the surgery itself, maybe we did not have enough cases, fortunately, but there has not been a perforation. And we will also have to dim the light for the endoscopy. If we do the endoscopy, we will also dim the light, not to cause inflammation, and we will even switch off if possible. This is something you have to consider, and I think it's a valuable comment. This is dangerous, but if you know it, then I think it can be handled. It's similar with the period after the photodynamic therapy. It's also dangerous for the patient, and this is also some criteria, I think, for selection of the patient. If the patient does not understand that he has to adapt slowly his skin to the light, then he's not eligible. If he's maybe a little bit confused due to age or whatever, then maybe he's not a good candidate, because then eventually he would just sneak out to the light because so nice sunlight, but done.
And the second question to the radiochemotherapy in terms of neoadjuvant, we have made excellent experiences in the esophageal cancer, in the rectal cancer. It is applied, we wait for surgery, and then later go in, and this is no problem at all, not more morbidity. Why is it so different in the cholangiocarcinoma?
The problem is for neoadjuvant therapy, radiation therapy, the toxicity is not very high. Now is absolutely decrease with the use with a new modality for administered radiation therapy, IMRT, surely, and help us to avoid local side effect. The combination with drugs sometimes represent the most toxicity, hematological toxicity, but there is also another problem because the response, the rate response, it's not very high, and it's good to have a stable disease, but downstaging it's rare, at least in my experience.
You're already happy if you have stable disease and can go in and do surgery, as we do, as I said, for example, in the esophageal or rectal cancer.
It's the reason because we have not data on neoadjuvant radiochemotherapy in cholangiocarcinoma. We don't have a lot of study, only small cases serious.
Just a comment about the natural history of locally advanced high local angiocarcinoma after chemotherapy. The UK ABCO7 study is cisgem or cisgem followed by SBRT, and that's currently in the feasibility phase. When we worked out the numbers to that, to see whether it was ever going to run, we looked at the outcome of the patients from ABCO 2, 3, and 4 following cisgem chemotherapy with localized high local angiocarcinoma, which was about a quarter of the patients were in that situation, and about half of those died from disseminated distant disease and about half from local complications.
Can I ask about, how are you imaging to do your target delineation? Are you using MRIs and how?
We use CT with a contrast enhancement during simulation and image fusion with MRI. Yeah.
And bearing in mind that the surgeons have quite a few patients who have an R1 resection, how accurate do you think that is? Because you're pretty narrow margins, haven't you? What, 5 millimeters? 10?
No. PTV margins. It's different if you use a gated treatment, but otherwise in radiation, we free breathing, we use PTV 1.5 centimeter in cranial, caudal, and 1 centimeter and lateral and anteroposterior, because the movement of biliary tract is important. Yeah. For radiotherapy, sometime we use for radiotherapy stereotactic patient a technique of breath hold, so we can give a small margin in this case.
But this is going to be in a few centres. If it's ever going to be done, it's not going to be done in lots of centres, is it?
But when you have an R1 resection, which you probably have very rarely...
No, I don't have this rarely, because the problem is not the distance in the bile duct. The problem is the perineural invasion, and which is surrounding the bile duct.
Do you have any idea while you're resecting where potentially you might have a problem? Because I'm just thinking of us, then you could put some markers and it would at least be easier for us to delineate where we should irradiate after the surgery, or you cannot predict where it might be R1.
This is very simple. I can show you immediately on the scan where the R1 problem is.
And then you could put markers there so that we...
No, I tell you on the screen where the markers
while
should be.
you're busy. Yeah, okay.
Because it's exactly there where you have the anastomosis, so where you see the conjoined with the small bowel.
You know, Thomas, I'm a simple radiation oncologist. I do like a signpost. You know, it's,
Yeah, okay.
it's very
You
nice
get-
for the
you get a
surgeon to show me,
signpost.
but I do like a signpost.
If it is the anastomosis, then that we can clearly see on a CT scan.
Yeah, yeah.
Stop,
Yeah, that's where the R1 is.
Okay.
Because you
Interesting.
basically anastomose to the remaining bile duct, and if the pathologist says it's R1, that it's exactly there.
Okay. Any further questions from the audience? Okay, I think we should close this session then. Thank you very much indeed.